Hi everybody and welcome to our module on neuroembryology. A few weeks after the egg gets fertilized, the developing embryo forms into layers that go on to form all the parts of the body that you know, and these are called the germ layers. So the mesoderm layer in the fetus goes on to form the cardiovascular system and things like muscles and bones. The endoderm layer goes on to form liver and lungs and the GI tract. But what we're going to talk about today mostly is the ectoderm, and this is what forms most of the central nervous system. So there's a surface portion of this ectoderm, and that forms things like the anterior pituitary, the lens, and the cornea. There's a neural tube, which is a very important structure we'll talk about in a minute, that forms the brain and the spinal cord. It also forms the posterior pituitary and the retina. The anterior and posterior pituitary have different embryonic origins, and that's why they have different functions in the adult. And then finally, there's a portion called the neural crest, which forms the autonomic and sensory nerves, and it goes on to form the skull. So the neural tube is one of the most important embryonic structures, not only because it goes on to develop so much of the nervous system, but also because of failures in neural tube development are some of the most common neuroembryological abnormalities in babies. So to form the neural tube, which will go on to form the neural system, the whole process starts with something called the notochord, which is an embryonic structure. And it secretes signaling molecules that drive this process. And one of the signaling molecules has this very unique name, the Sonic the Hedgehog protein. There's a funny story behind this. There were a number of proteins at the time that looked like hedgehogs, and they had different hedgehog names. And the researcher who discovered this one, who ultimately went on to win the Nobel Prize, well, his kids were playing Sonic the Hedgehog all the time at home on a video game, so he named it Sonic the Hedgehog. So in any event, these signaling molecules induce the overlying ectoderm to convert and become what's called neuroectoderm. The neuroectoderm then becomes the neural plate, and the neural plate folds into the neural tube. It also goes on to form something called neural crest cells. And importantly, all this occurs around days 17 to 21. And at this point, most women don't even know they're pregnant. About half of all pregnancies are unplanned. So women can already have a problem in the fetus before they're even aware they're pregnant. And we'll talk about this later, but that's why women of childbearing age are encouraged to take folate if they think they might get pregnant at all. And incidentally, the notochord in the adult is what goes on to form the nucleus pulposus, which is the intervertebral discs in the spinal cord. So here's a picture to help make all this neural tube development make a little more sense. So here's the ectoderm here, and this is the notochord right here. And it's going to trigger this overlying ectoderm to become things like the neural crest cells and the neural plate. And the neural plate is going to involute to form the neural fold, and then the neural fold will close to form the neural tube. Now, if the neural fold doesn't close and part of it stays open, that's how you get spina bifida, which we'll talk about in a few slides. And this is just a picture of the spinal column in the adult. So here's the spinal cord in the middle, and these are the vertebral bones. And right here is the nucleus pulposus. It's the intervertebral disc, and that's the remnant in the adult of what was the notochord in the developing fetus. So the neural tube has a series of bulges and swellings that go on to develop the structures in the adult, and you need to know what they are. So initially, it forms three primary vesicles, which are really just bulges of the tube. And the first one is called the forebrain. It's also called the prosencephalon. The second one is called the midbrain or the mesencephalon, and this will persist into the adult and be the midbrain that you know from studying brainstem anatomy. And then finally there's the hindbrain, which is also called the rhombencephalon. These three primary vesicles form five secondary vesicles, which are called the telencephalon, the diencephalon, the mesencephalon, the metaencephalon, and the myelencephalon. So this is easier to understand if you look at a picture. So over here on the left side of the screen are the three primary vesicles. Those are the prosencephalon, mesencephalon, and rhombencephalon. And they form the secondary vesicles, which are all listed right here in the middle of the screen. And those go on to form the structures that you know in the adult. So the telencephalon forms the cerebral cortex and cerebrum. The diencephalon forms important structures like the eye, the thalamus, the hypothalamus. The mesencephalon will stay the mesencephalon and be the midbrain that you know from studying the brainstem in the adult. The metencephalon forms the pons and cerebellum, and finally the myelencephalon forms the medulla oblongata. And the primary brain vesicles are present at about 3 to 4 weeks in the embryo, and it's about 5 weeks when you see the secondary ones form. So the clinical relevance of all this embryology I've been telling you about is there are congenital defects of the nervous system that happen when baby's nervous system doesn't form properly. So the most important ones are the neural tube defects. The first of these is spina bifida, and this is when the caudal or bottom end of the neural tube doesn't close. The next one is anencephaly, and this is when the head or rostral end doesn't close. There's also a neural tube defect called an encephalocele. There are also cephalic disorders we'll talk about, like holoprosencephaly, and then finally there are disorders of the posterior fossa, which are basically cerebellum problems, and these are the Kari malformations and the Dandy-Walker lesion. So we'll go through all of these in this module now. So neural tube defects happen when the neuropores fail to close in the fourth week. So what are the neuropores? Those are openings of the neural tube. And remember I showed you that it starts with a neural fold and then it has to close into a tube. And if it doesn't close and one of those neuropores stays open, you will get a neural tube defect. If you have the rostral neuropore fail to close, you get a defect at the head. Rostral means towards the head. And if the caudal neuropore doesn't close, that means you get an opening down towards the tail. So spina bifida is when the caudal neuropore fails to close posteriorly and you don't get bones growing around the spinal cord and meninges. We'll talk more about that in a minute. Anencephaly literally means without head, and that's when the rostral neuropore fails to close anteriorly and you basically get absence of major portions of the brain and skull, and this is not compatible with life. We'll talk about this in a minute. There are some well-known risks for neural tube defects that you should know about, and one of the biggest is decreased folic acid intake in mothers. And this is why women who are pregnant or may be pregnant are advised to take folic acid. And remember, the neural tube defects occur in the first few weeks before most women even know they've missed a period and they are pregnant. So women of childbearing age are advised to take folate if they think they might become pregnant. Type 1 diabetes is a risk, obesity is a risk, and then there are two anticonvulsants, valproic acid and carbamazepine. I talk about these in the seizure module, but they are well-described risk factors for neural tube defects. There are three forms of spina bifida, all caused by failure of the caudal neuropore to close appropriately. So let's talk about the three forms now. The first type is called spina bifida occulta. In this condition, the bones around the spinal canal fail to fuse normally, as shown in this picture. However, the meninges and the spinal cord are normally positioned. Usually the only abnormality you can see on physical exam in this condition is an abnormal tuft of hair or a dimple over the spinal canal. That's why it's called occulta, because the spinal problem is hidden. The next type is called a meningocele. In this condition, the meninges bulge out from the back of the baby. However, the spinal cord remains in the spinal canal. And then the worst type is called a myelomeningocele. In this condition, both the spinal cord and the meninges are bulging out from the back of the baby. This type of abnormality is almost always associated with a Chiari malformation, which is an abnormality of the cerebellum. Here's a drawing of the spinal cord in cross-section just to make this more clear. So on the left side is a normal spinal cord and vertebral column. In spina bifida occulta, the only issue is a gap in the bones, but nothing is protruding through that gap. Remember, there's usually that abnormal tuft of hair, or sometimes a bump or hemangioma is present. In a meningocele, the meninges are bulging out through the gap in the bones. And then finally, in a myelomeningocele, both the spinal cord and the meninges are bulging out through that gap in the bones. And this is the type that is almost always associated with a Chiari malformation. So you should know that spina bifida defects can usually be detected in utero. This is part of why women undergo prenatal screening and prenatal ultrasounds. And in fact, there are surgeries that can repair the defect, and some of them can even be done in utero, although others are done right after birth. The problem is that unfortunately a lot of children, even if they get the defect repaired, are left with permanent neurologic deficits. So you've probably seen children in wheelchairs, and what they had was spina bifida when they were born, and even though it got surgically repaired, they've never fully recovered the ability to walk. Some of them are paralyzed, some of them have permanent bowel and bladder problems. And this is a fetal ultrasound of a baby with spina bifida, and you can see the defect in the back of the spine. So anencephaly is another neural tube defect, but in this case, the portion of the neural tube that fails to close is up near the head, and the forebrain and brainstem get exposed in utero, and when they're exposed, they don't develop normally. This is not compatible with life. The baby will be stillborn or die shortly after birth, and you can detect this on ultrasound. Babies will have what's called an open calvaria. The calvaria is basically the formation of the skull, but it will be open, and the fetus has a frog-like appearance, and that's a classic description for board questions. Also important to know is that the mother will have polyhydramnios. So polyhydramnios means excess amniotic fluid. And the way amniotic fluid is produced is it's the baby's urine, and then the baby swallows it to take it back into the body. But babies with anencephaly can't swallow the amniotic fluid, so the mother is going to develop polyhydramnios. And then one other type of neural tube defect is called an encephalocele. Down here on the right, there's a picture of a baby with one of these. This is where brain or meninges herniate through a skull defect. It's the least common type of neural tube defect, and the most common site for this to occur is the occipital bone. So alpha-fetoprotein is a protein synthesized by the baby in utero, and when the level of this protein is high, it suggests a neural tube defect. It's a fetal-specific globulin. It's made by the fetal yolk sac and some of the fetal organs. We actually don't know exactly what the purpose of this protein is in the developing baby, but we do know it's excreted by the fetal kidneys, and at about 16 to 18 weeks, you can measure the AFP level in the mom's bloodstream. So you can draw blood from the mother and detect alpha-fetoprotein. If the level is high in the mother's bloodstream, this may indicate a neural tube defect. Now, interpreting alpha fetoprotein levels is complex, and a high level doesn't necessarily guarantee a neural tube defect, but it is suggested. When the level of AFP is high, mothers are usually recommended to get follow-up tests, and often this is an amniocentesis where a needle is inserted and some amniotic fluid is drawn out for testing. If the level of amniotic fluid AFP is high, that strongly suggests neural tube defect, and they will also check something called the amniotic fluid acetylcholinesterase level. If both of these are high, it strongly suggests a neural tube defect. When you do OB rotations, you will see women who are pregnant come in for what's called prenatal screening, and one of the things they are screening for are neural tube defects in the baby. Partly they'll do this by ultrasound. As I showed you before, you can see some neural tube defects by fetal ultrasound, and they will also check the maternal blood level of alpha fetoprotein. Now, they are also going to screen for Down syndrome at the same time. There are markers of Down syndrome by fetal ultrasound. One of the classic ones is for the nuchal area at the back of the neck to become translucent, meaning it's clear and dark on ultrasound. And they will also send serum markers in the mom's blood for Down syndrome. Usually what they send is what's called the triple screen. So they test the mother's blood for AFP, estradiol, and HCG. AFP is high in neural tube defects, like I said, and it's actually low in Down syndrome. And then levels of estradiol and HCG are abnormal in the mother's bloodstream when there's Down syndrome. So this is what prenatal screening is all about, and it's looking for neural tube defects in addition to Downs and other problems. Okay, now we're going to talk about holoprosencephaly, and this is a cephalic malformation. It's failure of the prosencephalon to cleave. I'll show you a picture of that in a minute, but remember the prosencephalon was one of those developing areas of the neural tube, and the left and right hemispheres of the brain, which as you know are supposed to be separate, do not separate. It usually happens during weeks 5 to 6. And it is a failure of signaling molecules. That sonic hedgehog protein, again, is implicated, and this protein has so many effects. It's part of why the researchers who discovered it won the Nobel Prize. The key findings for babies who have holoprosencephaly, you can't see their brain and that's not separated, but when you look at the baby, you'll see facial abnormalities. The mild forms are cleft lip and palate. If it's severe, they may have just one eye. That's called cyclopia. And it's associated with some other chromosomal abnormalities like trisomy 13, trisomy 18, and it's also associated with the fetal alcohol syndrome. And so here on the left side of the screen is a normal prosencephalon, and it's separated into two parts like it's supposed to. But over here on the right is a holoprosencephaly prosencephalon, and the cerebral hemispheres are still stuck together, and the optic neuroectoderm did not separate. So when you look at the baby's face, if it's mild, you might just see a cleft lip, which is what that is right here. If it's severe, you can see cyclopia like this, where the baby has just one eye. Next, we're going to talk about the Chiari malformations, and these are all abnormalities of the cerebellum. That's the way I always remember it. They are a group of disorders numbered 1 through 4, but you only need to know numbers 1 and 2 because 3 and 4 are incredibly rare. And they all involve downward displacement of the cerebellum, and there's a picture of that down here. So the cerebellum has started to move downward through the foramen magnum, and there it can compress the brainstem, which is one of the problems in Chiari malformations. And it can also obstruct CSF flow and give hydrocephalus, and those are the two major issues that children with Chiari malformations have. So we'll talk about the Chiari-1 malformation first. This is where you have an abnormal shape of the cerebellar tonsils, and the tonsils are these small rounded structures at the bottom of the cerebellum, and the tonsils get displaced downward below the foramen magnum. Here's a picture of it over here on the right side of the screen. And it's very high yield to know that Chiari-1 malformations are associated with syringomyelia. We talk about syringomyelia in the spinal cord module, but this is a picture of it over here on the left side of the screen, and it's a cyst in the middle of the spinal cord, and it causes very specific symptoms. Because this is a smaller malformation than Chiari-2, patients often don't have symptoms until they get into adolescence or adulthood. The mean age when people get symptoms is 18 years. One of the first things they get is headaches, and this is because their meninges are being irritated by the malformation. They classically complain of something called a cough headache, where their headache is worse when they cough. They also get cerebellar dysfunction, so they can have ataxia, and they can have cranial nerve dysfunction because that herniated cerebellum can compress the brainstem and give you cranial nerve lesions. So a Chiari-2 malformation is also called an Arnold-Chiari malformation, and this is downward displacement of the cerebellar vermis and tonsils. It's much more of the cerebellum that's displaced. This usually causes a brainstem malformation. You can get something called a beaked brainstem on neuroimaging because the malformation is compressing the brainstem. And remember what I said before, these patients almost always have a spinal myelomeningocele, and because of that, this is usually detected prenatally because the myelomeningocele can usually be seen in a fetal ultrasound. So the big problem with these malformations is that it blocks the aqueduct and gives hydrocephalus. And remember what I said, before there were shunts available in the 60s to lower the pressure in the head, most babies with this malformation died from hydrocephalus. Because of the myelomeningocele, there's usually paralysis below that defect. And just keep in mind that hydrocephalus in infants doesn't present the way it does in adults. So adults will come in complaining of a headache, but a baby can't complain of a headache. So what will you see if a baby has hydrocephalus? You'll see a large head circumference on growth curves. So when you do a pediatrics rotation, you always measure the circumference of the child's head and compare it to a growth curve. If it's too large, that may suggest hydrocephalus. Babies can have their anterior fontanelle distended. The fontanelle is the space below skull bones, and it seals in childhood, but it can be distended in babies. The sutures, which are the spaces between the skull bones, can be widely split. And there's a classic finding of a cracked pot sound. It's also called McEwen sound when you percuss the skull in babies with hydrocephalus. I don't think anyone does this anymore, and these problems are usually picked up in utero or right after birth, so the children never go on to get this sick. But if they did walk in with an undiagnosed Chiari-2 malformation and hydrocephalus, these are some of the things you might see. So the last malformation we'll talk about is called the Dandy-Walker malformation, and this is a developmental anomaly of the fourth ventricle. It's also often detected by ultrasound in utero, and you get poor development of the cerebellum is the bottom line. Technically, it's hypoplasia or agenesis of the vermis. The cerebellar hemispheres, they look flattened when you image them, and they're separated from each other by something called a Dandy-Walker cyst. And you get cysts in the fourth ventricle which cause hydrocephalus. Hydrocephalus is the main problem in this abnormality. There are many, many associated symptoms and conditions, and this is really rare, and I don't think it's worth your time to remember them all. But suffice it to say that affected children will have hydrocephalus, delayed development, and they will have motor dysfunction because they are not crawling and walking normally. And this is a brain image of a patient with the Dandy-Walker malformation. And what you see is that the cerebellum is small and there's a huge space in the back of the brain. And if you see that, that's a classic finding for Dandy-Walker malformation. And that concludes our module on neuroembryology.